Уважаемые друзья, dear friends, продолжаем работу нашей.
Ladies and gentlemen, we would like to continue our excellent conference. Our speakers are here. Looks like they are here. We have the quorum, so to say. Sergei Nedamolkin, are you here? So we have the next speaker, dear colleagues, and the thematic session on vascular access in trauma. We'll speak about vascular access and invasive BP monitoring for severe trauma. Yes or no? Sergei Nedamolkin, the floor is yours, and please mind the timing. Good afternoon, dear colleagues. My presentation is dedicated to the measurement of arterial pressure. It's the main parameter of hemodynamics. It's one of the vital signs for the resuscitation experts when they treat the patient with unstable hemodynamics in the OR. And of course, we always have a possibility to see any changes in the arterial pressure. This is helpful because it helps to make decisions on the fast change of the strategy of treatment and follow-up of these patients. With all the advantages, measurement of arterial pressure, of course, has its downsides. We have to give away the technical possibilities, time limits, and also we sometimes compromise in favor of less opportunities in critical situations, in emergency situations. The first thing we do when we try to measure the arterial pressure is to think about the approach. Well, the radial artery is the most common one to measure the pressure because of the small diameter, unstable pressure of a patient and vasopressive support of the patient. So catheterization of this artery without visual support is not so possible. Well, it is considered that the artery has collateral lesions and Allen test is done instead. Apart from radial artery, we also use the subclavian, femoral, and iliac arteries. The femoral artery is the second possible approach among critical patients with large diameter vessels. But and then if you have a catheter for a long time, infectious complications are possible. What are the methods? Needle catheterization, transfixation after you puncture two walls, Seldinger method. If it's not possible, we do a section of the lesion. We use vascular surgeons for this. Well, among critical patients, it's not probable. And then we'll do IVUS. Ultrasonic navigation is in all areas of medicine today, including intensive care and resuscitation medicine. And a specialist of ultrasonic navigation is, of course, a great help to the team. And even among unstable patients and patients who are adrenaline supported by 1 microgram per kilogram of weight per minute. I'm sorry. We can visualize the lesions, the arteries, and successfully catheterize an artery. It's a matter of minutes. But this is possible if a specialist is mastering the technique. If our specialist is more used to palpatory method, of course, he will better do it without ultrasonic control. And ultrasonic navigation, according to the studies, does not lead to the minimization of complications. It can improve catheterization and blood flow only at the primary successful catheterization. Apart from catheterization, for the right measurement of pressure, of course, we need to have a good measurement system which is able to detect the systolic pressure peaks, etc. We have to be able to put a catheter 5 centimeters below thoracic part to define the pressure at the at the base of artery. Well, systolic pressure, systolic reduction, diastolic rig, and diastolic flow that eventually lead to the finite diastolic pressure are measured, and on the monitor we identify it as a diastolic pressure. The mean pressure is calculated automatically depending on the location of the catheter in this or that artery. The curve of the pressure may change. The further we are, the more distally the artery is located, the higher the systolic pressure is and the lower the diastolic pressure is, but in general the pressure is not changing much. Why do we like so much to do the invasive monitoring? As I told you, this gives an immediate opportunity to measure arterial pressure in current or anticipated hypertension. It helps us to detect intraoperative hypertension earlier than the non-invasive monitoring does. It has an opportunity of, well, we have a good approach in case we need to sample blood to test it. Besides, maybe invasive monitoring is the only way we can measure the pressure among the patients who suffered from burns or they had traumas of limbs. Besides, it is possible with invasive monitoring to monitor the central hemodynamics. We can use it for angiography, embolization, and other types of visualization assessments. Besides, the invasive monitoring helps us to assess the volemia. Well, we see that as the systolic pressure is changed and the heartbeat is changed, we can assess the volemic burden of the patient. The factors against invasive monitoring are as following. Very often we are in urgency. The specialists don't often master this technique. It requires knowledge and education. It's expensive. Very often complications are possible. Dissections, false aneurysms, thrombosis, and there are risk factors that propagate these complications. And to conclude, I want to mention the indications for invasive monitoring. This invasive monitoring is indicated for the patients with unstable hemodynamics. Catheterization location of choice is femoral artery. Also, the approach that was done for femoral occluder. Invasive approach to measure arterial pressure is also indicated for the patients who are hemodynamically stable, but they have internal hemorrhages of unknown origin or location. Patients with concomitant cardiovascular pathologies can have invasive catheter preventively, and the method of choice is a radial approach, and ultrasonic navigation can also be a supportive method. Thank you very much. The discussion will be in the end of every presentation.
Be a debate of sorts between Dr. EVTM, who's going to talk to us first about only IR and vascular surgeons can do this access.
Dobry den, everybody, and thank you very much for the organization for inviting me and to be part of this excellent conference and this exciting battle. So I'm a vascular surgeon, and vascular access in trauma, well, maybe only interventional radiologists and vascular surgeons can do this. I have no conflict of interest to disclose. There are some lessons which everybody knows from the advanced trauma life support, some important principles. The lessons which everybody could learn from this is that you have to do no further harm. That's very important, and especially when obtaining vascular access, you can make a lot of damage. And of course, you have to treat the greatest threat to life first, and time is of essence, and there's only one safe way. So there are a few important things. As I stated before, do no further harm. But also very important is the team. It's all about teamwork. You cannot win this game by yourself. And even with an excellent team, like my favorite football club, you won't make the final all the time. So that's like in real life. As stated before this morning, it's all about access. The EVTM basic principles are very clear. The E is equally to the airway. So I personally believe that vascular access has to be done by the most skilled person who's available at that moment. It can be very hard, and I provoke to use the ultrasound. So please do no further harm. In this setting, a simple Seldinger technique has been demonstrated in this video. You see an infiltration of lidocaine, and when it's getting simple, or when it's getting easy, it looks very simple, but you can do a lot of damage here. You can make all kinds of complications, as already were talked about in the previous presentations. And even in very skilled hand like this, it takes you at least a few minutes to have a good vascular access. So training is essential, and that's where I want to talk about. Very recently, well, actually this month, we published a paper with our group where we assessed the vascular access training for the Reboa placement. You can find it on PubMed. This study was performed during the EVTM workshop in Urubu in September 2017. In this workshop and in this training session, 21 individuals participated, of which there were 5 residents, 2 emergency doctors, 9 surgeons, and 5 instructors. It was a formalized curriculum. We assessed the basic anatomy in the femoral region. We tested that, the knowledge of it, and also the very basic training in the access for materials for the Reboa placement. So the candidates has to prepare an endovascular toolkit, and then they achieved vascular access in the model. It was a hybrid model with a silicone tube on the pig. And after that, they had to control the bleeding in zone 1 with the Reboa. The first results of this study were there was no difference in understanding of the surgical anatomy, so the basic knowledge is very good. But, however, participants in a consultant position had a significant better technical skills. That was very clear. As you can appreciate from this table, you see that residents were able to perform the Reboa placement, so from needle in the hand till the moment to balloon insufflation, well, in this model, they took about 3.5 minutes. Surgeons in consultant positions need about 2.5 minutes. And instructors, we were very well skilled, trained, needed just a little bit more than 1 minute. So training is essential. When you train, it will go faster. At this moment, an article is in preparation where we assessed and evaluated vascular access by non-specialists like nurses, paramedics, and military personnel, and also in ER physicians. Also, this was very standardized with video capturing, and we assessed again the anatomy and this was scored by standardized scoring forms. At the end, at this moment, we are busy with study preparation. We are waiting for approval of the medical ethical committee to perform a training in real trauma patients with, for example, an HLS shock class of 2 or more. So in conclusion, ladies and gentlemen, training is absolutely necessary for successful, safe and fast vascular access. So please avoid collateral damage. And let the most capable person do this in these circumstances. So depending on the situation. It's all about teamwork, so please do not hesitate to ask your colleague. Thank you very much.
So now we're going to hear from the opposition. Lori Hanlon is going to argue that anyone can do this vascular access for us. Go ahead, Dr. Hanlon.
Okay, dear Chairman, audience, and Sorital, there won't be much of the debate because I think we agree most of the things with Daniel. But let's have a look. So everyone can do the access. So like we heard and like we know from our own experience, I think any doctor who has got some training can do the access. And what we already know, and Daniel is looking that further, is that actually also non-physicians can do the access. There are some studies, for example, here a study on non-physicians trained by best course, and they can learn steps to put the sheet in and put the reboa in. And there is another study, duty military medical technicians without any prior endovascular experience. They can do it after training, but still the access is the challenge. And like we heard, more experienced you are, more faster you are. Like we heard, the instructors can do the access 3 times faster compared to residents, but still the residents, they can do it. And how is it in real life? There is one nice study from Baltimore saying that there was a series of 21 consecutive reboa patients saying that the median time to complete CFA cannulation was 4 minutes and 7 seconds. So basically, that reflects the reality. It reflects the thing that the vascular surgeon, the interventional radiologist, he's not always there. We are there, and that's basically the median time it takes from us to get the access. So about 4 minutes in real life. There are challenges. Obesity. Maybe your puncture needle is not long enough, you need to dissect deep down. Hypotension. Maybe you can't see any pulsating artery. When you get your needle in, there will be no spurt of blood coming out. Hypoxia. How can you tell if you are in vein or are you in artery in case with severe hypertension? So it's hard to tell. It's not that easy. Vasospasm. There are no tolerances. The diameter of the vessel, the artery, is very, very small. And maybe your hands might be shaking a bit because you are not so familiar with the access. So there are challenges. Calcified lesions, our trauma patients are nowadays older and older. Limited experience, maybe suboptimal environment, pre-hospital setting, military setting. It's not so easy always. So everybody can do, but not always on the first attempt. This result is coming from the ABO trauma registry, saying that in 55 cases in that registry, the primary attempt was successful in half of the cases. So you need to prepare for the second attempt, maybe for the third attempt. This is coming from 86. 15 patients, saying that in open cut-down, 8% of failure rate, and 60% of failure rate in percutaneous punctures done without ultrasound. Systemic review, 1,355 patients, only 0.66% of introducer insertion failure. I don't believe that. There must be more. This study is coming from Japan, saying 12% of failure rate. This is coming from London, pre-hospital setting, 32% of failure rates. They never actually got the access in. And this is from France. They have a long tradition of doing riboas in France, 6% of failure rate. So what does it tell to us? In summary, yes, everybody can do it, that in optimal atmosphere, optimal place, optimal lighting, after training when the artery is optimal. But maybe you are not getting there with your first puncture. Maybe sometimes you are not getting in at all. So you need to have the protocol. How long, actually, how many times you try to establish your access, how many punctures you are willing to do, and you need to have your bailout solution. What are you going to do after you have actually failed the access? So I finished my talk here, concluding that yes, everybody can do it, but not always. Thank you.
Any comments or questions from the floor? I do have one comment really for the panel, or question. We've all talked a lot about training and how important it is to get early arterial access and how difficult that can be. Do you have any thoughts about what is the optimal number of arterial access procedures someone needs to do to become proficient? And then once you become proficient, how often do you need to do it in order to maintain that skill set? And I'm talking about for percutaneous access.
I'd like to talk about the ultrasound guidance because it's nowadays more and more common and it should be recommended. So if once we get the skill set of the CVC catheter by ultrasound, probably it's the similar technique. But the difference between artery and vein is big because it's a pulsatile flow. So some practitioner was surprised at the arterial flow. So CVC ultra guidance insertion and at least 5 or 10 clinical cases in elective cases with the supervision of the consultant. So the skill set is differ in each individual, but I think that is a minimum.
And also I'd like to address the thing Daniel was saying. So basically you asked about the training, and keep in mind that when you have the ultrasound, the best training is that when you do your vascular cannulations, just peripheral vascular cannulations, use your ultrasound, for example, for brachial veins, and train. But the artery, with the vein you can mess, you can puncture it many, many times, but with the artery you don't want to mess. And that's something you really need to, when you train, you also need to train so much that the trainees get the ideas of the complications and how to avoid the arterial complications regarding the puncture.
If I might comment, several things. First, I think that you don't really learn until you, I'm sorry for the language, fucked up, which means you don't really know until you did it wrong. Personally, as the one that did it wrong many times, like high puncture, then you understand the consequences, and I think this is one of the major things we saw with our residents. You have to do it wrong once, as we did a week ago, to understand the severity of your acts. Just interesting to know, is there anesthesiologists here, ICU people here? Can you raise your hands, people from the ICU, anesthesiology, intensive care people? So here there are several, as I see, these are people puncturing every day. So I think there's a huge difference about training of anesthesiologists that are doing it every day, or vascular surgeons that do it every day to someone else in my world, or emergency doctor that do ultrasound guided. In Sweden, when I started my training, we did all the aneurysms blindly, blind puncture, and you can learn it, but you pay price. I would put a number of 20 to learn, but as said, you don't really learn until you made a major problem, in my world anyway.
And I'd like to continue. Tal was addressing the anesthetist. You guys, you have the ability to puncture. You puncture a lot. But what I've seen in Finland is that anesthetists, normally you guys, you are used to use radial artery. And you do double wall puncture. You go through the vessel, the anterior wall and the posterior wall. Then you come back and you are in. And when our anesthetists are doing that on femoral, the access, they do the double wall puncture, which is not recommended. So you need to only puncture the anterior wall, and that's something we need to, at least in Finland, we need to address to anesthetists all the time, only anterior wall.
Спасибо. Вопросы из зала, пожалуйста.
Now questions from the floor.
The practice or the volume, it's also attitude, because we get all the time complications from the cardiology unit to correct. So if you don't pay attention, as Lauri does very well, and you don't do it meticulously, then you just think that, well, I just do the puncture, then it goes wrong.
One practical step, if I might add, that we teach in the workshop, and I don't know, this is only our experience, if you puncture and you have an introducer and it doesn't work, leave it there, as long as it's not bleeding, and we fix the problem later.
1 minute, one question. Thank you. Если сосудистый
If the vascular access is not your end goal, but a means to achieve your end goal, why not teach each and every doctor, never mind his main specialty, to have percutaneous access to the vessel? So in the critical situation, the first of the doctors who comes across this situation will perform vascular access, or do you think otherwise?
AABC, access airway. So in critical patients, the first line you put in is the arterial line in the femoral.
Thank you. Другие эксперты?
Other experts, other opinions, maybe?
Maybe one remark. It's absolutely. It should be very nice if everybody can do it, but it really strongly depends how many patients you see. You need a number of patients to keep the skills, not only for training, but also if you're already trained, you have to do it on a regular basis. Otherwise, you will face the complications very soon.
Don't harm the patient.
Спасибо, спасибо. Нам нужно двигаться дальше.
Thank you. We have to move forward. Thank you. And our next block is called endovascular surgeon in a shock room. The first position of endovascular or IR surgeon is Vasily Suvorov. Highly esteemed chairs, highly esteemed colleagues, we represent the view of general surgeons. You see the names of our team. These are all general surgeons who are trauma leaders in their shock operating room and are dealing with managing of severe patients with polytraumas. The topicality of traumas raises no doubts. As of today, if we look at different fields and areas, the number of patients in people working in difficult production areas is quite high. Besides, we have lots of patients who receive traumas or injuries when falling from heights or in car accidents and other situations. Nothing new if I say that trauma is a leading death cause in people under 44 years. We represent the military field surgery hospital, which is a first-level regional center with all the possibilities for dynamical monitoring and diagnostics of all the damages of patients with polytrauma. In our hospital, though we do not have hybrid OR, we stick to Presto concept where when we carry out diagnostics with CT, simultaneously with decision-making and intervention, the shock OR is next door from computer tomograph. In our hospital, we use three main strategic lines to all the patients. First is selective conservative tactics, NOM, simultaneous use and management of all the damages, and number three is several steps surgical tactics. Today I'm going to deal with thorax and abdominal injuries. We use special algorithms with a focus on making all the damages more objective based on CT, angio, and ultrasound. Indications for endovascular surgery in our hospital are presence of extravasation of contrast inside the damaged organ in stabilized patient and the signs of vascular damage. And now a few cases. Patient, 28 years, after car accident, blood pressure 80 to 40 on the trauma site, pneumothorax, ribs fracture, and left clavicular. CT angio shows the subclavicular artery damage after the deviation of the thyrocervical trunk. It seems to be an ideal case for endovascular surgery and the placement of a stent, but the surgeon who was responsible decided to have open surgery that is quite traumatic, but it means additional blood loss, isolation of the damaged artery, multiple attempts to restore circulation in the extremity, and the temporary processes into the artery. All this led to the irreversibility of the ischemia, and at the end of the day, the extremity had to be amputated at the level of the brachial joint. Unfortunately, later on, the patient died because of the complications. Another patient, 30 years old, also car accident. He was a driver of a car, and he bumped into another car. Upper mediastinum was damaged. Also, the abdomen was damaged. Splenectomy, laparotomy were carried out, and then he went to hybrid OR. And aortic damage in the ischiumous region, third-grade damage was identified. In the CT room, then into the hybrid OR. And very drastically, the blood pressure went down. Bright red blood was noticed with a drainage. The rupture of the aorta was diagnosed in the descending part. An attempt was made to place a temporary prosthesis. No success, unfortunately, and the patient died on the table. Another patient also got trauma, upper mediastinum, CT performed, third-grade damage of aorta diagnosed. radiological OR, then back to shock OR where we have C-arm with angio equipment, and stent graft was placed. On day 14, the patient was activated, and 2 weeks afterwards discharged. The problem in the abdomen as of today with parenchymatous organs damage may be resolved only endovascular, be it kidney with pseudoaneurysm. We carry out embolization of this pseudoaneurysm. As for spleens, damaged spleens, no problems at all. And the percentage of splenectomies in our clinic is minimal as of today. Another case, the patient fell from the 6th floor, hemiperitoneum, low blood pressure, indications for laparotomy, in the course of which we diagnosed the damage of the left branch, left lobular branch of the vein in the area of bifurcation, portal vein. We were considering catheterization of the portal vein and placement of stent graft into the portal vein. As I've said, no problems with damaged spleen in our hospital. Very rarely we remove or resect spleens where they treat them conservatively, or remove aneurysms. When there are pelvic injuries or wounds, we also carry out angio, at which, like in this case, we diagnose the internal iliac artery damage. Its embolization was carried out, and the patient became well. On the whole, our modest experience shows possibilities of endovascular surgery in the shock OR. In short, we can formulate them as follows. There are pluses and minuses. On the one hand, endovascular IR surgeon needs specific equipment and achievement of endovascular hemostasis, but IR surgeon always tries to complete their intervention endovascularly. We have to find the golden something in between so that we act in the interest of patients. Thank you.
Don't need the endovascular surgeon is Dr. George Oosthuizen from South Africa.
Thank you, Madam Chair. Right, I'm going to be talking on endovascular surgeon. Do we need him, yes or no? A typical case at my hospital would be something like a 23-year-old man who pitches up with a stab at the base of the neck with a weak radial pulse, and he's hemodynamically stable, so we do a CTA on the patient, and we find that he's got a pseudoaneurysm of the subclavian artery. So, of course, your options, as we've discussed all day, are either you can stent it or you can do an operation on it. So, there it is in grammatic form, diagrammatic form. If you have endovascular facilities, I think most people would probably opt for stenting. But if you don't have endovascular facilities, either you can refer or you may need to operate. And that is the situation at my unit in South Africa. We do not have endovascular facilities, so on most of these patients we would opt to operate. Now I have a number of questions for you. The first is, what did we do before we had endovascular facilities anywhere in the world? We operated on them. Secondly, what do we do when our hospital has no endovascular facilities? We operate. Number three, how many units in the world do not have endovascular facilities? Many, a great many across the world. Number four, what do we do when a particular vascular injury is not suitable for endovascular management? We operate. Number five, what do we do when there is a contraindication to endovascular management? We operate. Number six, what do we do when endovascular management fails? You guessed it, we operate. All right, so let's just have a quick look and see what can and what cannot be managed endovascularly. So if we talk about stenting, you can stent almost anything in the body. So just running from top to bottom, the innominate artery, the subclavian artery, and of course the extension of that, the axillary and the brachial. You can stent the carotid arteries. You can stent the descending aorta, the superior mesenteric artery you can stent, the renal arteries, the infrarenal aorta, the external iliacs, the femorals, and even the popliteal artery. So that's as far as the lesions that you can stent. But which lesions can you not stent? There aren't many. I would say this part of the aorta, the proximal aortic arch where the main vessels are coming off, that you will probably need to operate on rather than stent. And that zone 2 of the aorta where the visceral vessels and the renal vessels come off, I think that you will need to operate on as well instead of stenting. So that was stenting. What about embolization, coiling, if you like? Again, you can coil almost anything. These small branches coming off the superior aspect of the subclavian, the internal thoracic artery, the vertebral artery, you can stent, you can coil. The vessels below the knee, as we've seen in one of the presentations this morning. Of course, you can coil the liver, the spleen, the kidneys, the pelvic vessels, including the gluteal vessels, and the profunda femoris. And if you put them all together, then in a long list like that, then you can see that you can treat almost any vascular lesion by endovascular means, maybe with 2 exceptions as I've indicated there. But that is if you have endovascular facilities. If you don't have endovascular facilities, you can operate on all of those lesions. Okay? And that is the comparison between the two. Now, I have to be honest and say that if I did have endovascular facilities at my hospital, I probably wouldn't operate on all of those by preference. Some of those I would treat preferentially by endovascular means, and some of them I would preferentially operate upon. That's my personal preference. You can disagree with me. I won't run through the list, but the point is just I don't think one should opt only for operative management or only for endovascular management if you have both available. Now, those were the arterial lesions that are manageable by endovascular means. But what about patient factors? There are certain patient factors that mitigate against endovascular management, and that would be an unstable, cold, coagulopathic patient, a patient who has allergy to contrast medium, a pregnant patient, somebody with very poor renal function, and of course when there's an inadequate landing zone for the stent. But guess what? We can operate on all of those. The only time I probably would opt for endovascular management ahead of operation is when a patient is unfit for a major operation or unfit for a general anesthetic. So, weighing the benefits, in terms of endovascular management, you don't need big incisions, and you can probably get your patient ambulant much quicker and get them out of hospital quicker. However, you do need some form of anticoagulation or antiplatelet therapy, and you need long-term follow-up, and secondary interventions are necessary every so often. With surgical management, on the other hand, with the big operations, yes, we have more in-hospital complications, post-operative complications. Yes, we have longer hospital stay, but there's no need for extended anticoagulation or antiplatelet therapy, and there's no need for extended follow-ups. And secondary interventions are rare with operative management. So, in summary, for endovascular management, we need an endovascular trained person, we need special facilities, and we need special equipment. And many units, probably most units across the world, do not have this. In addition, you need certain patient conditions to be met, and you need certain vascular conditions to be met, as I've shown. However, for operative management, you need an able surgeon with an able anesthesiologist, you need a theater, and you need a vascular set. and most units across the world have this or should have this. So in conclusion, not all injuries can be managed by endovascular means, but pretty much all injuries can be managed operatively. There are virtually no contraindications to operative management. So, do we need an endovascular surgeon or an endovascular trained person? I would say they are a nice to have, but they are not a must have. And so, for the junior trainees in the room, I would say, go ahead and learn the endovascular techniques, but whatever else you learn, make sure that you learn how to operate. Thank you.
Thank you. Пожалуйста, вопросы из зала.
Thank you. Questions from the audience. Thank you very much for your very interesting presentation. I have a question to you. Please, I have a question to you, dear colleague from South Africa, Mr. Uzitin. So you're saying that if there is no endovascular department in the hospital, it's not necessary. Am I right to understand you? So there is no need to open a new department in a clinical center. If you have no endovascular unit, there is no need to have one. Am I right to understand you?
So we, in most cases, in these sort of cases, we have to decide.
Well, that I understand, that you have no endovascular, but do you need it?
Patient, or do we operate on the patient? And in most cases, we prefer to operate on the patient because we don't know what they might do in transit. Would I like to have an endovascular facility? Yes. Am I working on getting one? Yes.
Вот это другой разговор, потому что из вашего выступления я понял, что вы...
Well, that's another story, because from your presentation, I understood that you are kind of against endovascular surgery.
Нет. Хорошо. Теперь вы...
Okay. You showed the advantages of endovascular surgery, and you showed only two positions pro-surgical approach: aneurysm of aortic arch and aneurysm of infernal part of aorta when endovascular approach is not helpful. But you forgot that there is a debranching, a surgical technique of debranching, upper and lower. And after that, you do an endovascular closure. This is a low trauma operation, while open surgery on aortic branch has a high level of mortality. So isn't it easier to do debranching and bridge it all with stent graft?
Absolutely, I accept that, but that takes it another level of complexity on top of that, which most units will not be able to deal with.
Я понял, просто много молодежи, понимаете, чтобы не показалось.
Yes, I got it. We just have lots of young people sitting in the audience. I don't want them to make an impression that it's so bad. Endovascular surgery is the main therapeutic method. 80% of all the patients with all aortic pathologies in Europe and in the US are treated endovascularly. So please be very cautious when you are saying things, because they may create a wrong impression.
Thank you very much for your comments. I agree, but my job was to present the flip side of the argument.
У меня вопрос к нашим экспертам.
I have a question to our experts. I am a proponent of old school, and my teachers were saying any manipulation can be done by someone who can eliminate the complications caused by this manipulation. I believe that any surgeon, general surgeon, who has a hematoma or pneumothorax, when he has the catheterization of vessels, he can do this. Can a PCI operator do this, or someone who has no surgical skills? I doubt.
And you have to know what you're treating after the treatment. So return to what we spoke before. I think people can do this, but the question is if you're doing the right thing for the patient, you know how to continue afterwards. So I do think a lot of people can learn procedures, but the question, I just put a stent graft in the aorta. Do I know what to do with it next step? Do I know how to evacuate the hematoma or to treat the patient, the ICU treatment, etc.? This is just my point of view.
And just one comment. I know in our institution, very busy elective vascular practice that's very endovascular heavy. And so our trainees are getting a lot of exposure to endovascular techniques, but not a lot of exposure to open repairs. And so as a trauma surgeon, sometimes we do have to go open because we're there and maybe we shunt or whatever and come back with the vascular surgeons another day. But I think one of our challenges is how to ensure that our trainees that are not training in the open area have the ability to at least start the exposure and get the case going while they're waiting for their vascular colleagues to come in from home. In your institutions, what solutions have you come to try to help trainees obtain the proper training in vascular exposures and open techniques?
This is very simple. We bring George, we bring Lowry to Sweden, and this is a huge problem because, including myself, I cannot maintain this level without training with these guys, for example, or you, Lowry, or others.
And I'd like to remind the course called ASSET, one-day course. I think it's 10 hours on cadavers. Only thing you do during that course is to open up and get the clamp on. Open up, get the clamp on, and then wait for vascular guys to come in. So that kind of training is needed for our residents.
And if the trauma surgeon covers the endovascular procedure completely, and if they can treat the complication well, it's ideal. But it's almost impossible for the world. So I'm not a surgeon, so sometimes I need to ask the surgeon to help me, but vice versa. Sometimes I help the surgeons and to embolize something. So all we have to do is to know the right person to help me. So that is a minimum. So we don't have to cover everything by one person, in my opinion.
Спасибо. Вопрос.
Thank you. Question from the audience. And
about the speech of Dr. Oshusen, seems to be that he likes surgery, and unfortunately he doesn't have good or mediocre interventional radiologists, and then he has to operate everything. I'm appalled to think that in a country like his, they don't have interventional radiologists. You know, we have to be together with the surgeons. We, in Richmond, Virginia, by the way, we train the surgeons to do interventional radiology, to do endovascular surgery for 6 months. And then, of course, Dr. Oshusen says that everything should be operated in because he has no interventional radiologist. And I will suggest to him or to everybody to get interventional radiologists with experience, and then half of the operations, or most of the operations, or all the operations will be eliminated. But unfortunately, I am the only one here. I don't know if anybody here is interventional radiologist, a good one with experience like yours truly. I've been doing this 50 years, and then in my situation, you know, I feel like I'm alone here, and everybody's doing surgery, and nobody does interventional, and I think we're giving a wrong message to the young people here. We need interventional radiologists, and they are very easy to train. We train them in 1 year and become good. And we train the vascular radiologists to be interventional radiologists to do endovascular surgery in such a way that in the United States, we don't have vascular surgery anymore. We have endovascular surgery. Thank you.
Возражение нашего финского коллеги, please.
Objections from our Finnish colleague, please. Your comments?
I think the discussion is relevant because also vascular surgical trainees don't get exposure, and we are doing nowadays a lot of surgery together with GI surgeons for oncovascular cases, and that's kind of saved us from doing a lot of only endovascular stuff. But I think we have the intelligent people who write about human behavior and human development divide human behavior and development to personal, interpersonal, and intellectual. And this session is about the intellectual development of ourselves. And I think we are now too much concentrating on the personal development, and I think Tal shows us a good example of the thing that we often lack, which is the interpersonal development. And that's, I think, the key to success here, and not talk about who's angioradiologist and who's surgeon.
What is questions? That's all? Okay.
Okay, so we're going to move on to our next block, which is going to be focused on Roboa and experiences with Roboa across the world. Our first speaker is Gad Sheikh from Israel, who's going to talk about Roboa technique and their experience in Israel.
Good afternoon. Thank you so much for the invitation to speak at this conference.
Israel. Спасибо. So I would like to share with you our lessons learned with the introduction of this technology of Roboa. So we have a humble experience with 15 cases. Last one was applied yesterday, actually, when I was enjoying a nice tour on the Nieva River here. So my colleagues put the 15th Roboa successfully. So the lessons that we learned in this time were like this. First of all, you need, as was mentioned before, to have good learning. So we passed with all the residents and attending surgeons that deal with trauma cases. We gave them the opportunity. So we have 6 already that went through the excellent workshop in Örebro, Sweden. We put protocols according to the literature and that apply to our situation in our place. Mainly, the main points are actually what were discussed before. Who is going to do it? When? Who is the correct patient? And exactly what are the indications and contraindications for applying the Roboa. Now, we are dealing with especially ER surgeons and general surgeons, so the Roboa kits must be very simple. I'm not constructing too complicated with too many devices inside the kit. It must be kept as simple as possible. Now, I don't know why, but many surgeons have some obstacles with all the techniques of Seldinger and the wires and over the wire and the replacement of one device with another. So you must know very well the components of the kits, all the diameters used, which one comes first. So you see, I even wrote on the several parts of the set with letters 1, 2, 3, so it will be kept very simple, and people will not get confused with all the adrenaline when there is a real patient coming in shock to start to think which one is the first one and which is afterwards. Also, there are very, very simple things to remember. For example, on the left side, you right, I'm sorry. If you don't put the introducer, the sheath, until you hear the click, when you press it, it's not going to go inside. You're going to fail. Or another thing, over the tip of the balloon, there is a very transparent sheath. If you don't remove it, you'll not be able to put in the balloon. So really simple, silly things, but you're going to fail if you don't remember it. About the insertion, so we know you must be very accurate regarding the point of insertion. If it's too high into the, over the inguinal ligament, when you remove it, especially if you remove it, the injured vessel is not going to self-concealed, and you'll get retroperitoneal hematoma. If it's too low, you can enter the superficial femoral artery. It's very difficult to compress it. There is no bone against your compression, and you'll get a large hematoma or even extensive bleeding over there. So you have to remember it. Now, we talked a lot about how to perform the procedure. Patient is now with no decent blood pressure. You try to do it as fast as possible. So many do it blindly. But of course, the best way to do it is ultrasound guided. And only if there is no other choice, do a cut down. Positioning of the balloon. The best is to do it under fluoroscopy guidance. But again, sometimes you don't have it available, the fluoroscopy, or you don't want to waste too much time in order to do more X-rays. So in many occasions, you do it according to topography. So if we are talking about zone 1, we are going according to the manubrium. If you do it zone 3, just a little bit or above the umbilicus. For example, in our second case, we put it exactly the level of the umbilicus. The result was, oops, I'm sorry. Go back one. The result was, anyway, the result was a pseudoaneurysm in the iliac artery. So you have to be very accurate to the point of insertion. Inflation of the balloon. It's better to fill the balloon with contrast material. It should be at least 1-to-1 ratio, water and contrast material. Otherwise, it's getting very sticky, and once you want to deflate the balloon, you're not going to deflate it completely. It's going to be stuck over there. Volume of the balloon. It's written on the balloon 30 for the one, for example, the one that we use, to use a volume of 30 milliliters. But for most young patients, the diameter of the aorta is such that even 10 to 15 mLs are enough. So you don't want to overexpand the balloon. Dislodgement of the balloon is very crucial. You see it especially in zone 1 insertion. So once you get a good blood pressure, the balloon starts to be pushed downwards. You must do everything that you can to keep the balloon in place. If it's needed, we even take a young doctor, tell him to hold it with his hands to prevent it from dislodgement. Hello? I'm sorry. Go back to the presentation. Or out of time? Time. Okay, so one more sentence about removal of the balloon. First of all, remember to deflate it very gradually to prevent ischemia reperfusion and drop of blood pressure instantly to 0 if you do it too rapidly. And second point is when to remove the sheath. You can keep it in place, of course. You can use it as any other arterial line to get arterial blood gases or to measure the blood pressure. But you have to remember it's a quite large sheath. It can cause thrombosis and all the sequelae of venous thromboembolism, etc. So this is a question. Thank you.
Okay, thank you. We have a couple of minutes for comments and questions from the floor.
I'd like to ask your practice. You have your trauma team working on the shocked patient, and then the team realizes that this patient really needs Reboa. Is it the team, I mean the members of the trauma team who are already busy doing some other stuff, are they starting to work with the Reboa, or are you calling in a special Reboa team, so-called extra hands, to put the Reboa in?
No, we have trained general surgeons who do the trauma calls. They do most of the cases. In only 2 or 3 cases, we had almost accidentally the vascular surgeons with us. Usually they are not part of the trauma team, so they participated. In some of the cases, the anesthetist, who is part of a member of the team, he put the line and we continued with the balloon itself, but usually it's the trauma surgeon.
Yeah, comment on that. At least in our unit, the trauma team is so small. I mean, we don't have enough personnel to put the Reboa in case the patient needs much, other stuff, intubations, cannulations, all kind of dressings and stuff. So basically what we do, we have a dedicated trauma team, a dedicated Reboa team, 2 people, and they are called in if Reboa is needed, so we get their extra hands in case.
We don't have such a problem because, Israel is tiny, but in trauma, we try to mimic the Americans in everything. So we have a large, we are a large hospital actually. So we have the core team is anesthesists, 2 surgeons, 2 nurses, and the orthopedic. So it's not a problem.
You've mentioned that you had 15 cases, so a humble experience, around 10 to 15 patients like this per year. And you've shown the complications that may arise in the dissections that may happen. Don't you think that if in your hospital you have an interventional radiologist or a cardiologist, don't you think it is worthwhile to ask them to puncture? Because these are the people who are well experienced. They do this several times a day, every day almost.
They are more experienced than we are, but they are not available on the spot to come for the trauma patient.
You're right, this may happen.
Not there, and we cannot afford to ourselves to wait for them, because when the patient is with 60 millimeter mercury systolic pressure or less, or no pressure, you cannot wait. It's either to crack the chest, to open to do resuscitative thoracotomy, or to perform Reboa. And now we are gaining more and more experience, so I believe that very shortly will be all, and it's not so complicated. I don't know why. It's true also for myself. At the beginning, we talked about
not difficult, but you have to master it.
Different sizes, and it was like, I'm sorry, Chinese for us. But now, after a few cases, you see, it's nothing. It's just, for a surgeon, it's not a problem to learn it. And really, it's not a big, it's more, not the technique, I think. Now we know very well that the major point is actually the decision, thinking, now I have to do it, or when not to do it, and when to stop everything if it fails and to go straight to the OR. It's not the technique itself, it's more the thinking.
Здесь еще один вопрос, который очень важен.
There's another important thing. When there are large balloons, you use catheters with long shafts, and sometimes you have to suture the artery endovascularly. And for this, you will need either a cardiologist or IR specialist to suture well. Because in those centers where interventional radiologists or cardiologists are available, it is better to work with them.
When we started the program, we didn't start it like in a vacuum. I went to the interventional radiologist, I went to anesthesiology, I went to all the vascular surgeons, and we did it together. I told them, this is the situation, we can do the first steps, and then you'll go in. So if there is a case coming in, of course we call them, but the access is on us. They don't have the time. So later, happily, I will transfer the patient to their management, to continue the management. I'm not going with him and try to solve everything. I just get the access, I get good, I improve the perfusion to the heart and the brain, I get a window of time, and this time I can get more blood and plasma, I can perform maybe even CT that in another situation I wouldn't go with the patient to the CT. I can get these experts with me now, so everything is ready and they can continue. So it's, as mentioned in the morning, it's a collaboration of the entire team.
Вопрос со стороны.
A question from our experts, if any, or questions.
With Dr. Sheikh, who should get access and when we should get access? Reboa and get access, these are included in the resuscitation. This is not a treatment, just a bridge. So we cannot wait. And if we wait for someone else, the patient status is going to be bad. So we should get access before patient collapse. So we shouldn't wait. If we think about access, that is the timing to get access. But of course, I need to encourage to have the training, especially for the ultrasound.
I'd like to ask Prof. Shaket, how many times you have failed to get arterial access? And what is your protocol? How many minutes you allow your team to work on the access before you call it off?
I must admit that we don't have an exact time frame, you know, or times to attempt. It's not strictly written somewhere, but of course, if we do, there was only one that we failed, and we continued with open cut down. There was at least 2 or 3 cases that required 2 or more attempts, but most of them were very fine in the first attempt. And I've also recorded, several of them recorded. I saw the time. It takes only less than 3 minutes. If everything goes smooth, it's less than 3 minutes with the balloon inflated. So it's very reasonable. I think it's less than an experienced or better so a resident that attempt to do resuscitative thoracotomy. It takes much longer and less accurate. When you apply everyone that was in this movie, and they tried, who saw the residents put the clamp on the aorta without opening the mediastinal pleura and applying it somewhere in the deeps there, it's less efficient, I think, than a good balloon inside the aorta. So our main lesson is actually that I think it's a good procedure for the correct patient, and this is the main idea. We do it very, very selectively. Always to have a bailout plan. If it fails once, twice, don't, you know, continue to play in the bay and take the patient to the next station, probably to the OR. And that it's not the technique itself, again, it's not so complicated. But you must know exactly your kit and the drawbacks, and then you can use it. Thank you.
Не могу не задать вопрос с вашей стороны.
I can't avoid asking question. You have a huge experience, and we know that in your country, the military medical experience is great. Aren't you thinking about REBOR at pre-hospital stage?
Do you want me to go back to my place? It's a big debate right now, I must say, in Israel. Of course, it's very tempting. But first of all, we don't, most of our military physicians are very, very young. They just finished, I mean, the level of the battalion, for example. So they are very young. They just finished their internship and went to do their duty in the military. So probably they just spent a few hours, you know, they saw us in the operating room. I cannot trust them to do this. Even, you know, to put a chest tube, they call it surgery in the field, a chest tube. So to talk about Riboa, I think we are not there. Secondly, we are not Russia. When we're talking about fighting in Israel, the evacuations are from the front line to the hospital, 7 minutes flight. So I'm not sure, I mean, SADC here in London, they do it in the metropolitan of London. It's longer times and distance than from our front line to the hospital. So I don't think that it's really, really required in most of our cases.
Okay, thank you very much.
Thank you.
Okay, our next speaker is Dr. Emiliano Gambarini from Italy, who's going to talk about who is in charge for Riboa placement.
So, good afternoon, and thank you very much for the invitation. It's a great pleasure for me to be here again. So, waiting for my slides. So, I want to start because when I was working on my presentation, I read this article and these courageous conclusions, and so I get not so well. And then I read in the same paper, the same issue, I read this one, and so I thought that my speech is over. But after that, I go on, and I find something else, and in this consensus, with this consensus, my mood switched a little bit better, because panelists stated that trauma surgeons and vascular surgeons should perform Riboa, but due to heterogeneity all over the world in the trauma organization, even in other settings and other doctors with different background should perform Riboa if they are adequately trained and if there are local protocols. So this is, I want to start with an example. This is an emergency room real scenario. It's a 10 meters fall patient with, he arrived shocked in the emergency room. And as you can see in the pictures, in the first picture, you can see a trauma surgeon which is performing a preperitoneal pelvic packing, sorry, while the ER doctors is keeping closed the pelvis because the pelvic binder was opened to allow the surgeon to operate. And in the second one, and you can see, sorry, I go back a little bit. As you can see, there is an already in place the 4 French introducer sheath on the left, on the right groin. So in the second pictures, you can see the trauma surgeon is almost completed PPP, and the anesthesiologist is starting to upside the introducer because the patient is still shocked, and the anesthesiologist is now quite free because airway and breath is fixed, and so we start to upsiding the introducer. In the third pictures, you can see that the patient is, the shock is ongoing, and so trauma team decided to insert a Riboa. As you can see, the PPP was completed and the pelvic binder was again closed up, but the patient was still in shock, so Riboa was inserted. And in the first picture, in the fourth pictures, you can see the trauma surgeons, which is my friend Federico, who is now checking for the position, for the balloon position, and to fix the balloon to move to the definitive treatment. So I think that if we want to talk about who is in charge of robot placing, we need even to talk about where to place it, what we use, and why we do it. So I think that all of us would work in a theater like this, but I don't know why, but the hybrid room is always busy for elective treatment when a trauma patient is admitted to the emergency room. And so we have to think about something else, which is easier to have 24/7. And what we call surrogate hybrid room is a dedicated operating room with a C-arm. And we can't call semi-hybrid room. This is not a semi-hybrid room. We decided to call it the surrogate hybrid room. And in this room, we can work together, neurosurgeons, trauma surgeons, vascular surgeons, orthopedic surgeons, and interventional radiologists. So that what we do and when. I think that in pre-hospital setting, we need to use only balloons which are approved for a blind position, and obviously the only doctor available will do it, and he will do it in a dying patient to the hospital. I think that in emergency room, again, without fluoroscopy, we need to use only blind-approved balloon, and every member of trauma team, if correctly trained, could do it. I put into blanket interventional radiologists and vascular surgeon because in our experience, it's not so common to have them in emergency room. But if they are, obviously they can do it, and maybe they have to do it. And why we do it in the patient which is persistent shock after primary survey and PPP or resuscitative thoracotomy and bones external fixation. In a traditional operating room, again, I think we can use blind-approved balloons, and this is the theater of the surgeons, and so trauma surgeon and vascular surgeon should do it. And when we do it after damage control surgeons with already unstable patient who need to be moved to the angiographic suite. Another, in our surrogate hybrid room, there is a little bit difference between a standard hybrid room, because even interventional radiologists could work together with surgeon in this setting. We can use endovascular balloons, what the interventional radiologist or surgeon want to do it, because we are on fluorangiographic control. And when we do it after damage control surgery with a persistently shocked patient, to allow a damage control interventional radiologist to stabilize a little bit the patient, then to move the patient to the angiographic suite to get the definitive treatment. In the hybrid room, I think it's always different because we can do everything together, and the doctor who perform it will be interventional radiologists or surgeons, and we can make the patient treat the patient with persistent shock after damage control surgery. We can do immediately the definitive treatment, angiographic treatment, and even in this setting we can perform advanced non-operating management, and we can maybe go a little bit over guidelines to save solid organs, maybe. So this is a thing that it's very important for me. Time dramatically decrease going down in these tables, and probably in an hybrid room, reboa inflation is very reduced as an indication. So that what we need really is our setting-based protocols, and my conclusion with a very uncommon picture of my hospital, because a seaside hospital, and this was all covered by snow in 2012. Thank you very much.
Okay, questions and comments from the floor or our panelists? I'll ask you a question. When you started to do this, did you get any pushback from any of the specialists within your institutions? Has it been relatively easy to implement REBOA at your hospital, or has there been any hurdles that you've had to overcome, and how did you do that?
No. We find we have no problem of work together in our settings. We used to work together, especially in our surrogate hybrid room, which is an obliged situation. So that it was not very hard to introduce this procedure. I have to say that it was an idea by anesthesiologist to start this procedure, but I think that every specialist will go through with this thing. I have to say that we changed our surgeons in 2015, and we use more REBOA before this change because surgeon before 215 didn't perform PPP. And so after introduction of PPP, we dramatically reduce REBOA position, and maybe Tal see it in the registry because our cases drop down all over the year.
Вопрос такой. У меня нет опыта никакого.
Here is my question. I have no experience with REBOA whatsoever, but I'm interested. How many fringes is the system in REBOA? How many fringes?
I know what we started with the Coda balloon, so the introducer sheet was 12 Frenches. Now we use a 7 French introducer dedicated for the balloon we are using now.
Очень хорошо. Ну тогда.
That's great. Can I ask you something? Why don't you use transradial approach then? Because you will easily go and work with aorta wherever you need. For example, you want to work below subclavian artery. Why don't go transradially? Because you will go into the true lumen. Because when you go through femoral, you can go to the false luminum, like the previous colleague was showing. When you go to the false luminum, can you use transradial approach? Or maybe approach from the elbow side. And less traumatic, by the way. So maybe cubital or transradial approach.
Anesthesiologists are most friendly with the radial approach, but I know that coming down from the high for REBOA is anecdotal in literature, and so we didn't try the courage to do it.
I have just a comment, if it's okay with you. I have some cases that we did from above. In a trauma and severe injured, there is a major problem as an interventionist I want to see with the fluoroscopy. They have to intubate. It's a lot of other issues. It's very hard to work on this area. I wouldn't do it blindly and let it go down. I have 2 or 3 cases we did, and they were not that easy.
Спасибо. Спасибо.
Thank you.
С удовольствием предоставляю слово.
With great pleasure, I want to give the floor to one of our speakers. It's Laura Moore. She will talk about REBOA in the United States. She will present multi-center trial results. Please.
So thank you again for the privilege of the podium. I'm going to spend the next few minutes going over some data that has not been published yet. So you're actually the first audience to hear the results of our recently completed multi-center Department of Defense funded REBOA trial that we just completed in the US. So I'm going to go over some of the results from that. I don't have any conflicts of interest. So the purpose of this study was to evaluate patients that were undergoing REBOA with the ER REBOA device, which goes through the 7 French sheath, at 6 level 1 trauma centers throughout the United States. And I have the trauma centers listed here: Houston, Shock Trauma in Baltimore, LA County in California, Denver Health in Colorado, University of Washington, Harborview in Seattle, and then Emory Grady Hospital in Atlanta, Georgia. These were our 6 participating institutions. And because this study was funded by the Department of Defense, the goal really was to get really detailed, high-quality prospective information about how we were using REBOA for the management of emergent hemorrhage control in patients with truncal hemorrhage. So we captured data specifically looking at the ER REBOA device, but we also looked at some other variables related to what happened or what did we find at laparotomy in those patients, how many patients required resuscitative thoracotomy, and then we obviously followed those patients throughout the 30 days after their admission to capture outcomes and other complications. This was a tremendous amount of data that we captured, and for the purposes of time for this talk today, I'm really only going to focus on the patients that underwent REBOA and save the discussion for the open management for another time. So pretty standard inclusion and exclusion criteria. Adults, which in the U.S. we say as patients that are 15 or older, with evidence of hemorrhage below the diaphragm. And the key thing here was we had to make the decision to do something about that bleeding within 60 minutes of the patient arrival. So these are true emergent and unstable trauma patients. Interestingly, and not entirely surprising to us when we designed the study, we had some very high volume centers. Houston and Baltimore and Denver were relatively high volume REBOA users relative to the other sites, LA County, Grady, and Washington, where they really don't use REBOA very frequently. This has created some interesting discussion about center effects when you look at the results, because about 80% of all the patients in the study came from one of 3 centers, and so the practice patterns at those centers are really strongly influencing the results in this data. So when we look at the breakdown, we enrolled 75 patients in the REBOA arm in about a 12-month period of the study. 80% were blunt, which is pretty typical for our U.S. trauma patients. Very high injury severity score, median of 34. And the majority of these patients had a zone 1 occlusion, so 63% of patients had zone 1. This is really the first time we've been able, at a multi-center level, to report on the insertion lengths. So for zone 1, the median insertion length was 46 centimeters, and the median inflation volume, so how much volume we were putting in the balloon, was about 10 cc's. The ER REBOA device, for those of you who aren't familiar with it, is a 24 cc, 32 millimeter compliant balloon. So only about 10 cc's was required to occlude the aorta. Zone 3 occlusion, about a third of the patients had that, and the median insertion length was 30 centimeters, and the inflation volume, again, smaller than what we would see in zone 1 at about 8 mLs. Now, when we look at procedure details, and I know this is small, and again, we had a tremendous amount of information that we got out of this study. Again, we had 75 patients that we utilized REBOA in. The majority of these in our institutions in the U.S. are being placed in the emergency department. A few things to note about the centers. The emergency departments are equipped with digital radiographs, but there's not fluoro, so we're not placing these under fluoro, but we're not placing them blindly either. So sort of the standard of care across these institutions is before we inflate the balloon, but after we've inserted the catheter, we get a plain radiograph to confirm position of the catheter in the appropriate place before we inflate the balloon. The exception would be for patients in arrest, which we often will just go ahead and do a blind insertion because we don't want to stop CPR for that. Some of the other interesting things, it takes us about 10 minutes from the time the patient arrives in the emergency department until the time that the surgeon pulls the trigger and says, let's go ahead and do a REBOA. The range for that was 4 to 19 minutes. So again, it's not the only thing that's going on in these patients. Maybe they're getting intubated, we're getting access, we're starting transfusion and seeing if those patients respond before we make the decision to move on to REBOA. The other thing that I thought was really interesting was the time. So this is the first time we've had really high quality data, direct observation of how long does it actually take us to do REBOA. And so from the time the surgeon makes the decision until the balloon is inflated, the median was about 7 minutes. So I think pretty quick times, and in some centers we noticed that it was faster than others. Higher volume centers had faster procedural times than some of the lower volume centers. But again, this is the median across all of the centers. And then finally, in terms of times, the other thing everybody always wants to know about is how long can I leave the balloon up? Again, median inflation time from the time it was inflated till the time it was completely deflated was about 55 minutes. There's certainly a range in there, 35 to 94 minutes. But one thing I want you to think about when you look at that number of 55 minutes is it's not 55 minutes of complete occlusion. Most of these patients had cycles of partial deflation to see what else was bleeding, and if the patient's blood pressure dropped, the balloon would get reinflated. So we're not talking about 55 minutes of complete inflation because that's really not the practice at the centers that were participating in this study. Other procedural details, again, we've talked a lot about ultrasound guidance and what we think is safe. Only about half of the time, though, are our centers using ultrasound guidance. About a third of the time we do percutaneous, and then about 20% of the time we're doing open cut downs. I will tell you, a lot of the open cut downs were happening in patients that were CPR in progress, but if you have access early, it's certainly easier to go ahead and transition that 18-gauge arterial line up to your 7-French sheath for those patients that were in arrest. Again, we're primarily using plain radiographs to confirm position. And then another really interesting finding for the patients that we were putting the Roboa in with CPR in progress. So these are patients that are in arrest at the time we decide to do Roboa. We had about a 60% rate of ROSC, or return of spontaneous circulation, with balloon inflation, which I thought was pretty exciting. When we looked at complications, we only looked at the patients that survived more than 24 hours. You have to live long enough to develop a complication. So when we looked at that, not surprisingly, we had a fair amount of acute kidney injury. Again, I know the graphic is small, but when you looked at it by the duration of occlusion, you can see that there seems to be some correlation in zone 1 with longer occlusion times, more than 30 minutes, having a higher rate of acute kidney injury, but it's not a uniform thing to see. And then as you can see, the mortality, the best mortality was observed in the zone 3 patients, so these would be patients that we presume have only pelvic hemorrhage and don't have intra-abdominal bleeding, and as a result have a lower mortality. The overall 30-day mortality rate for the entire group, including those patients that were undergoing CPR, was about 52%. And again, the most common cause of death, not surprising given the patient population, was hemorrhagic shock. We were very focused also on access complications and identifying those. I won't go over all these, but it was a relatively low rate of access complications, sort of the standard things that you would see, dissection. We had one incident where the balloon was inflated in the wrong position for 20 minutes. But we did not have any amputations, and we didn't have any ischemic complications, so no dead bowel, no spinal cord ischemia reported in this series of 75 patients. Minimal device issues. We had a couple of balloons that ruptured because the practitioners put in more than 24 cc's, and that will cause the balloon to rupture. We had 2 cases where the catheter couldn't be removed because the balloon wouldn't fully deflate, and it required a cut down to pull those balloons out. And then a couple of issues with the catheter not being flushed or coming out of the packaging bent. In conclusion, high volume centers really predominated here, and we noted a trend towards faster procedural times and a more likely to choose to perform a Roboa in an arrest case. Relatively low complication rates and low device-related issues. And again, I think some of the patient selection is still challenging. We had a 60% rate of ROSC for patients in CPR, but most of those patients did not survive to hospital discharge. Future directions, I think, we still are looking for randomized data, but this observational trial will help inform that. Lots of interest in pre-hospital Roboa and how we could potentially utilize that for both military and civilian applications. And again, use of Roboa in non-trauma related hemorrhage and cardiac arrest. And with that, I will thank you for your time and ask you if you have any questions for me.
Спасибо, Лаура. Очень интересно.
Thank you, Laura, for your very informative talk. And questions, please. First, the audience. Was everything clear? Then maybe comments. Let me ask a question, though. Yes, please.
For another excellent presentation. Having a long clamping times uphill, do you ever put heparin in the patients? I didn't see that.
We do not routinely use heparin in Houston or Baltimore. I haven't asked the other sites. It's pretty unusual for people to report heparin use, but Chuck Fox, who is also a contributor from Denver, might be able to comment about whether or not they use heparin at his place.
Yeah, we haven't used heparin, but as you know, we preferentially do this in patients with pelvis fractures, and frequently they're going to the operating room for that management, and we don't know about their head. Right. So because of the high incidence of TBI, we've not given heparin, but we are very careful to try to keep our occlusion time to 30 minutes, and we usually have orthopedic residents that will put the external fixer on while we're packing.
Вопрос с зала, пожалуйста, еще один.
More questions from the audience, please. Thank you so much for your presentation. Please tell me, how do you follow up the patients post-operatively, the patients who had Reboa, especially if you inflated the balloon in zone 1? Are there any specifics of the follow-up of these patients? Maybe you have to use the experience of toxicologists or other experts.
The question was, what's the follow-up for patients, especially those with zone 1 occlusion? So all of our patients that have Reboa, we want to evaluate for access site complications. So at about 24 or 48 hours, we routinely get a vascular ultrasound at the site of puncture to make sure there's not a pseudoaneurysm formation. As you saw, there was one pseudoaneurysm reported in this series of 75. In terms of bowel ischemia, we have not seen that. And typically, we're in the operating room, the balloon is down, but we're still operating. So just because the balloon is down doesn't mean the operation is over. Hopefully we've gotten hemostasis, but we may be doing bowel resections and reconstructing the bowel and other things. So we typically have our eyes on the intestine for a period of time before we actually close. And so I think if we identified ischemia, then we would certainly deal with it, but we just haven't seen it so far in these series. But again, a relatively short occlusion time of 60 minutes, and like I said, at most places it's not full occlusion at zone 1 for the entire time, which probably explains our low rate of ischemia.
Спасибо. Спасибо.
Thank you. And let's give the floor to our co-chairs. Thank you very much for your great presentation. Well, you showed us the experience of using Reboa in traumatology. And what about in obstetrics? Is there an experience of Reboa in obstetrics in the U.S.?
Of data. My personal experience is limited to 2 so far. One was for a trauma patient that had a placental abruption after a blunt injury and was bleeding into her uterus, and was peri-arrest, and we took her to the OR and we did Reboa for that case. I've done 1 Reboa electively for a Procreta case in conjunction with our high-risk MFM at the time of delivery and hysterectomy. The Reboa worked very well, but she did develop a distal thrombus that required a thrombectomy after we brought the balloon down, but it was recognized very early and dealt with appropriately. I think it's a great application looking at peripartum hemorrhage for Reboa, but I think their physiology is very different than our trauma patients, and so we really have to be careful about thrombotic complications in the peripartum patients, and I think we need to look more closely at, maybe we do use heparin in those cases because we know they're not bleeding from some other site. They're a great question.
Maybe I can just comment, there is now a postpartum registry starting by Dr. Karen Fox in Houston. It's a multiple open registry, so if you have cases, you can join, and I think we can get some data on this. We can give the email address.
So is there time for one?
Один. Only one.
Only one.
So Laura, thank you. My question to you, I have this fetish on the access, So did you include only the patients who actually had the Reboa, or did you include everybody who had the decision to have Reboa? So my question is, did you failed any accesses?
Great question. Yes, we did capture that. There were 77 patients where the surgeon made the decision to do Reboa, but you only saw data on 75 because there were 2 patients where there was a struggle with getting arterial access, and the surgeon decided to just move to resuscitative thoracotomy. So 2 out of 77, there was a failure of access and conversion to a thoracotomy instead.
Спасибо, спасибо. Я думаю, кто...
Thank you. I think those who didn't manage to ask the questions will do this after the next presentation. Thank you, Laura. Because the next presentation will be similar, but you're our guest, and we want to show you the Russian Reboa experience. So, Victor Reva. Dear colleagues, in my presentation, I wanted to tell about where Reboa came from. Reboa probably is the most often used term at this conference. The only competitor is vascular access, certainly. So the main idea of using balloon occlusion of aorta is stop the hemorrhage. The most traumatized patients, both in civilian times and during the wars, die from bleeding. So the main management method is to stop the bleeding. How you stop it, either from outside or from inside, doesn't matter. The main thing is to minimize the blood loss. Nikolai Pirogov wrote about 100 years ago that the new era will be started in surgery when we'll be able to minimize the bleeding without cutting or ligating it. How many patients with such finish of the operation will survive in our reality? I think it will be very minimal patients with very low pH, with base deficit, huge base deficit, and it's very difficult to provide adequate care and save such cohort of patients. Success means adequate resuscitation, hemorrhage control, and coagulation control. But the hemorrhage control and resuscitation are 2 main components. Adequate resuscitation is what people all over the world talk about nowadays. I've taken this slide from Twitter. Juan Duchesne, who wanted to come over to this conference, but unfortunately he could not. About a week ago, there was a conference in Brazilian Campinas, a global conference on damage control resuscitation, a new term that means to us resuscitational follow-up of damage control. And this term is even broader than damage control. There is a society that is trying to study adequate intensive therapy in severe traumas. The reality is such that our infusion transfusion therapy is looks like this. Up to now, 50-50, we provide medical care as a combination, transfusion and infusion therapy. One of the quotes from the book of Riripaniemi is from a chapter where he quotes Rip Pfeiffer: if you arrive to the ER and don't know what to do, start putting in drainages until somebody arrives who knows. Balloon occlusion is practically the same nowadays. You come, the patient is critically unstable, the pressure is 50 to 60, and if you do not do anything, he will die. Balloon occlusion allows us to relatively stabilize this patient. No unstable patients with a balloon, almost. What is Reboa for us? It is just a temporary means, it's a bridge, it's a tool that allows us to pass over from severe unstable situation to a more controlled situation. Unfortunately, we can't jump over this huge wave from prehistoric man to the advanced man of the 21st century. We have to develop gradually, and balloon per se would not resolve all the problems. We have to provide this care all together with resuscitators, with the control of coagulation system of the blood. The task is a comprehensive task. Reboa as a term appeared first and was used by Igor Samokhvalov. It was described in the Top Stand book, which we translated together with the EVTM Society and Tarhol Horror into Russian. And Igor Samokhvalov describes how it all came to life. He read an article after he came back from Afghanistan, an article by Carl Houston, and together with his disciples, Alexander Petrov and Dr. Zavrajny, they started this work. These are the 3 doctoral theses, where the first use of balloons in the 90s and the beginning of 2000, the use of balloons in different damages of lower vena cava and other vessels. And that's a dog for whom aortal balloon occlusion was performed. At that time, the technical solutions were not ideal, so they left the method for a while. But the same people who lose balloon occlusion in those days, they continue using it now. These are the cities, St. Petersburg and Krasnodar, Russian cities where these techniques are more or less introduced into practice. In the other cities of Russia, it is still the work of the future. These are the data that were provided to us by EVTM, Society Talhorer David. The contribution of Russia, not that little compared to other patients, to other countries. What are these patients all about? Look, no damages in the thorax, no damage in the abdomen. During laparotomy, we see a huge retroperitoneal hematoma. To open this hematoma without losing the patient, the proximal control is needed, either via thoracotomy or balloon occluder introduction that will allow us to proximally control the bleeding. That's how it happens in reality. It's a recent patient about a week or 2 weeks ago. The assistant compresses the area near the iliac vessels, and balloon was deflated at the area of aortal bifurcation, then revision of hematoma, ligation of the vein, PPP of retroperitoneal space, very unstable dynamics, and the balloon goes up in order to prevent the arrest of circulation. Spleen, 1 kidney were resected, patient was stabilized. The classical damage control, what we are talking about. Another patient, he fell from the height and fell on a fence. You see the groin was damaged very seriously. Arrested patients, when he arrived to the clinic, cardiopulmonary resuscitation was going on. First zone of aorta balloon was installed over the diaphragm. On the background of Lucas being performed, vein catheterized in order to perform massive infusion therapy. After the circulation was restored, the balloon was moved down to zone 3, from which the bleeding was continuing, and the tamponade of this wound was performed. Coagulopathy was developed, and the bleeding was continued. After the second tamponade, we embolized both the internal iliac arteries with relative stabilization of the condition, and the bleeding was stopped. Another case, a thoracic wound and damage to the ribs, spleen, blood loss of around 1.5 liters, balloon occluder, 50 millimeters hydrargium. Time of occlusion was 15 minutes. Balloon was removed and patient discharged. Pelvic ring damage with such a large hematoma. First pictures were performed with a balloon installed already. Patient was delivered without the pressure. He was stabilized. Tamponage of the pelvic, fixation of that pelvic was performed, and he was operated within the framework of damage control. No trustworthy difference in terms of 30 days mortality, but we're still accumulating the data. These are the balloons we're using to come, and our Russian balloon called MIT. You see the balloons that are registered, but we do not have balloons smaller than 10 French. We hope that very soon the Russian balloon will come onto stage, size 7 French. And this is how the large introducers are being removed. Who should perform it? What we discussed at our first session. Endovascular procedure has to be performed by a radiological surgeon, maybe somebody else, because we have to work very quick. Which professional standards do we have? For anesthesiologists and emergency doctors, it is written that they can monitor the condition of the patient on the basis of blood pressure. Maybe they need invasive blood pressure, and they can use the catheter installed into the artery. For the surgeon, it's even more difficult. Bleeding is stated here, but for the cardiovascular surgeon, it is written that they can cannulate main vessels and directly measure blood pressure. And radiological surgeon can carry out all these procedures. Semi-hybrid OR, which now turns into hybrid OR, pelvic ring with a special cutoff for the groin area, and thus we can catheterize the femoral artery. These technologies are being developed, and now we have ambulances with special bags with balloon occluders. We had the first case when the heli-drive team carried out catheterization of femoral artery and catheterized it at pre-hospital stage. Also, on battlefield, we can take such kits there. There were no cases described, but we have prepared such equipment. Prepared by one of St. Petersburg institution. It allows to automatically control the level of aortic occlusion. It is not complete occlusion, but based on proximal and distal blood pressure, the computer, by inflating or deflating the balloon, allows to evaluate the level of perfusion. In conclusion, we promote these technologies, but Rebo per se does not save the life of the patient. It is only a bridge to reasonable surgery, to hemostasis, and it is not worthwhile to introduce balloon occlusion per se. It is part of a concept how to manage wounded and traumatized patients in the 21st century based on the EVTM principles. Thank you. We have 4 minutes for questions. Welcome. Those who didn't manage to ask the questions to Laura, you may address them to Victor, because they are identical. Thank you for your presentation. When you use long term, more than 30 minutes aortic occlusion, is there a protocol for deflation of the balloon? Or is it always in a deployed state? And then what is the follow-up? How do you follow the patient up? So the question is how we deflate the balloon. We usually deflate, never mind how much it was inflated. We deflate it slowly. And rule number 1 is that anesthesiologist has to know about it. We tell anesthesiologists that we deflate the balloon, and the average speed is 2-3 ml in 30 seconds. For example, if it is Medtronic balloon that accumulates 12-14 ml, it will be deflated in the course of 7 minutes. We inflate quickly, we deflate slowly. More questions, please. Thank you for your presentation. Do you have experience of using Reboa in aneurysms ruptures? No, we do not have such experience. We cooperated with vascular surgeons from the EMS institution. They tried to introduce this technique, and maybe in the near future we'll have such experience. We, up to now, do not have it. More questions, please?
From LA. That was a great talk by both of you. Obviously, one of the challenges with the data is the heterogeneity of these patients. So comparing someone with zone 1 Reboa is very different than zone 3 Reboa for pelvic injury. My question is there a specific indication that you recommend centers that don't have a lot of experience with Reboa starting with, or do you think it's best to be more liberal with its use? Because although it's not that difficult of a procedure to perform, it still does take some training and learning curve.
So could you emphasize, because difficult to listen?
My question is, do you think that there's a specific indication that's best for a center to start with, for example, pelvic fracture with pelvic hematoma, or do you think they should be more liberal?
Okay, thank you. I would say that a specific indication for the trauma center who's a beginner in this particular issue is pelvic fracture. Pelvic fracture with hemodynamic instability, I think it's optimal way to start with this technique because it's relatively safe. It relatively easy, and you can start with puncturing the vessel at the quite stable systolic blood pressure. And the more difficult is to do it in cardiac arrest, in severe hypertension. So this is advanced technique.
Буквально тезисно от вопроса от экспертов.
And very briefly, questions from the experts.
Question, Victor, you aim for total occlusion. How can you tell when it's total? So when do you stop inflating?
So usually we confirm the position of the balloon using X-ray, and you see it's kind of mushrooming when it pushes against the aortic wall, and it's clearly visible on the screen on X-ray. Another thing is we cannot palpate the femoral blood pressure from contralateral side, or if this patient is severely hypertensive, we cannot find the flow using ultrasound probe or any kind of imaging.
And just one more comment to speak to the topic of if Reboa is coming to your institution and you haven't done it before. I think the key first step, and we've said this over and over again today, is early arterial access. So start putting in either 5 French or 18 gauge arterial lines on your hypotensive patients. Even if you don't think you're going to do a Reboa, get really, really facile with the access, and it's not just you being facile with the access, it's the nurses setting up the monitors and getting the A-lines hooked up. But if you're thinking about doing this, you've got to get really good at the first step, which is access, so start practicing.
Yeah, this is an important question because we now, I would say, a few, 5, 6 last patients we admitted to our facility. We started with early access at blood pressure about 90, 100, and it really impacts on further procedures.
Спасибо. Остальная дискуссия.
Thank you. The rest of the discussion will be backstage during the break. We have to carry on. The topic is extremely interesting, and I invite Oksana Rizanova, who will tell us about reborn for placenta percreta.
Good afternoon, dear colleagues. I would like to share my experience in using Reboa for the treatment of obstetric failures, placenta, percreta. Until now, we have obstetric hemorrhages, despite all the efforts in the structure of maternal mortality. Hemorrhages are cause number one. One of the reasons to develop obstetrical hemorrhages is the pathologies of placenta. In recent years, they increased significantly according to different authors. The US colleagues described 1 case per 2,500 deliveries, childbirths, and Chinese colleagues say they have 1 case per 533 baby deliveries, although in 30s these cases were much more rare. Why is this happening? Because the incidence of cesarean sessions is significantly increased today. In some countries, up to 50% of deliveries are done through cesarean session. And what is the biggest challenge here? During child delivery and pathologies of placenta, there can be a massive hemorrhage, up to 3, 5, and more liters of blood. Very often it ends up in hysterectomy, and up to 7% of cases it ends in maternal fatality. The therapy we need is massive transfusion, deployment of different coagulants, deployment of high doses of erythrocytes, and hemostatic therapy. In order to solve this problem, we need to stop the blood supply We need to occlude the vessels on this level approximately. This is the aortic level. So when we came to this understanding, we exercised a multi-step approach because we started from embolization or occlusion of the uterus artery. It was not efficient. And then we started doing the occlusion of the inner iliac artery, then external iliac artery. But if you look at the scheme, you will see that we still have the intact arteries leading to the genitals. And we couldn't reduce the hemorrhage volume. That's why in this particular, we started using the endovascular occlusion, balloon occlusion of aorta, the RIBOA on aorta, because even the ovarian occlusion was not efficient. For the first time, this method, RIBOA in obstetrics, was deployed in 1950s. Very few works published, 12 cases in Japan of using RIBOA in precretal placenta cases. There is a research clinical case report, recusative RIBOA with uterus rupture, and this is the biggest case report published by Chinese colleagues, 230 patients with placenta, previa, precreta, and RIBOA in this case. Here are our cases. This female patient had a history of disease. She had comorbidity. She's an obstetrician herself, and she knows that she knew about the technique we deploy. She came to us 1 month before the childbirth. She was in our clinic. Preoperatively, we did a catheterization of radial artery to invasively measure her arterial pressure. We did epidural anesthesia. We had ultrasonic control. The balloon was taken to above bifurcation area. After we took out the baby, we retrieved the balloon. There is a video, but I don't think we have time left. Well, it's almost a bloodless intervention. Blood loss was minimal. Otherwise, in other situations, if we didn't have RIBOA, the blood loss would be 3 and 5 milliliters, 5 liters even more. Next day, the patient was taken to the intensive care unit. On the 5th day, she was discharged from the hospital. This surgery is very interesting because we had Israeli colleagues traveling to us. They participated in this surgery, and we also exchanged experience. This experience is remarkable because the patient during pregnancy was diagnosed cervical cancer, and during pregnancy she had 3 courses of chemotherapy. During pregnancy she had laparoscopy, lymphoadenectomy, and the surgery was done in collaboration with oncosurgeons. We did the cesarean incision, a laparotomy, expanded hysterectomy of Wertheim. The time of surgery was more than 2 hours and 40 minutes. Time of occlusion, well, it happened twice that we did occlusion. In total, 29 minutes. First, we inflated the balloon when we were extracting the fetus, and then the bloodiest part of the surgery in coordination with oncosurgeons. The blood loss was 600 milliliters. Yesterday, we finally approved our internal clinical guidelines. We got the approval of the local ethical committee, so now we can really conduct these manipulations fully fledged. So since November 2018 till now, we had 8 interventions with RIBOA. 1 was with oncology as a comorbidity. You can see on the table these patients, as compared with a group of patients who didn't have RIBOA, took less time. Blood loss was much less. They were taken to the intensive care unit and then the regular unit much earlier. One of the patients had a complication, a thrombosis of femoral artery. no clinical manifestation. We just diagnosed it under ultrasonic control. I show you this slide to illustrate the difference in price. With Riboa and without Riboa. You can see that with Riboa, patients who have a cesarean section and they have the ingrowth of placenta, it costs 55,000 rubles, and the non-Riboa procedure is 200,000 rubles more expensive. That's why Riboa is a very promising method during child delivery with ingrowth of placenta. Thank you. We have time for questions. Thank you for your very interesting presentation. I have several questions. Number one, how do you confirm, which methods do you use to confirm that you have the true ingrowth of placenta? And second question, if in Russia we have only 10 fringe balloons registered officially, how do you suture the puncture, and how many punctures do you have for Riboa, 1 or 2? And one more question. Do your PCI operators do the prevention of thrombosis by injecting heparin? Let me start from your last question. The thrombosis prevention with heparin is done by anesthesiologists together with vascular surgeon. In prenatal center, we have a vascular surgeon. He's not on duty 24 hours. He's called for emergency situations such as ruptures, etc., while our anesthesiologists are capable of doing prevention with heparin, prevention of thrombosis with heparin. How do you close the puncture areas, and how do you make sure it's a true ingrowth of placenta? Well, we inflate the balloon above bifurcation enough, up to 2 centimeters of inflation, and we use introducer 8 fringe. It's registered in Russia. We work with them. Everything is mentioned in our guideline, and it is signed by our lawyer. So, and then we close the suture. We close it either with a bandage, with a compression, or you know, in obstetrics, we really want the woman to stand up right after the surgery to start taking care of the child, so we do the suturing. Who is doing the suturing? Anesthesiologists. Yes, they were trained. Alexandra Vladimirovna, apart from placenta ingrowth, what other indications in obstetrics do you have? Well, you know, these are rare cases in obstetrics. We collected all these cases to present here. The main problem is placenta ingrowth, and also the placenta, the cranial presentation of placenta. And what about the hemorrhages, afterbirth hemorrhages? Well, we thought about it, but in afterbirth hemorrhages, the embolization of uteral arteries is working very well. Thank you. Any other questions or comments from the panelists?
Partial Riboa. Did you try to use partial Riboa, deflate, inflate a bit actively, and try to work under this?
Well, we only had 8 cases, so we are not, let's say, that experienced. In one case, we were trying to do it. When the obstetricians wanted to check if it can work or not, we inflated and deflated a little bit. Hemorrhage started again, we inflated again, and hemorrhage stopped, and it was fine. Thank you.
Next speaker is Talhor, who's going to talk to us about Riboa for ruptured abdominal aortic aneurysms.
Hi again. It's again very nice to be here, and the work you're doing is, I think, it's quite amazing. I will take you just shortly through the ruptures and the Riboin rupture. This is again a part of the EVTM concept. And as I mentioned before today, in Sweden, and I see also my colleague from Zurich is standing at the end of the room, Zoran Rancik. We are doing, and several other centers, we're doing all the ruptures with endovascular method. It's a fact. You do it because you have different methods. You can work in a C-arm suite or semi-hybrid, as we can call it, or a hybrid suite in different places. And what you need is different technical things to do it. So you cannot just do it if you don't have tools. The tools you need is to have a fast CT, dedicated protocol. You have to have available stent grafts from different companies. It depends on your preparation. We do them mostly on local anesthesia if possible. And of course, RIBOA or aortic balloon occlusion, and I will speak about it. And then different other methods. And you cannot use just the RIBOA. This is a classic example. RIBOA doesn't solve anything. You have to have more tools. So most importantly, to get a good access, interestingly enough, and maybe Zoran Rancik from Zurich will comment, most of our rupture were done on a blind, total blind access method. And the majority, or all of them, were successful. So it's quite interesting, without ultrasound. You do it parallel, you get a 7 French inside for the ruptures. This is the routine kit. It's 7 French bilateral. If you need, you can do double puncture or different methods through and through wires, technicals to get stent graft in place. Ultrasound, more and more coming. Now it's coming, and we try to use it more and more. And when you get the CT, then you know what you have at hand, and then you have a ruptured aneurysm. This is one of the example. This is how it looked like. It's a mess. And then you're trying to decide if you can do it or not. And then you can use different methods. You can use methods to get the graft in place. This is what you want. But it's not always that easy, and at times you need to use more complex methods like chimney or double chimney or triple chimneys, and to use the balloon itself. So what do I do with the balloon? I use it to stabilize the patient in order to get things inside. These are some examples under the process how you can use it. At times it's successful, at times not. So the balloon itself, you use it only if you need it. So in stable ruptures, when they're stables, there's not really a stable rupture, but when a patient is with a MAP, mean arterial pressure above 60, 70, or systolic 100, we don't put the balloon. We have the access only if needed. We try, if you use it, the idea is not to occlude the aorta. The idea is to give the anesthesiologist a MAP over 60. So this is a huge difference. We don't use the balloon and just put it in and get it occluding the aorta, and that's it. And I think if we will look at the old RIBOA material from the States and other places, we will discover that this was the method used. You put it in and you go on with your things. We titrate. You take the pressure up, so the anesthesiologist is happy with you, say, okay, good, now I have pressure. And then we play with the balloon. During this time, me and my colleague would play with the grafts. We're trying to get in as fast as possible. And this is the example here in this film. So this is a partial RIBOA, and this, in my opinion, is the game changer. You don't need to occlude totally the aorta. In some of the cases, to keep the pressure until you get your solution, and the solution can be very complex with double balloons, sometimes triple balloons. I'm sorry for the mistake there, but RIBOA is a bridge to definite treatment, and to keep the patient alive, it's not a solution. And it's always better to have an infrarenal occlusion if possible. For long occlusion, you will pay a price, and the price is quite severe. Abdominal hypertension, abdominal compartment syndrome, and in my set of mind, RIBOA, it's a catheter, it's a minimally invasive method, but it's not. It's a highly invasive when you occlude the aorta for a long time. So you will pay the price, and this is the price. You can do decompression by laparotomy or TPA. There are different methods. Laparotomy is the standard method. Just to show how we think and work, we work with chimney. You get access from above, from below, different things to get in the stent graft in place, and again, Reboa if needed. These are some examples of how it would look like, and these are some examples with onyx embolization. Today, there is also the fill embolization agent. There are others like NBCA and others that you can prevent endoleaks and use it in chimney, double chimney, triple chimney, balloon inside, onyx only, etc., etc. These are some more examples. One of them is a very exciting Nelix graft that is now out of the market, but the patients are going around that there are endoleaks. You can solve it in different places, and this is an important tool. In our hands, I think we have quite good results, but we know that if we need to use the aortic balloon, the patient has problems. He is hemodynamically unstable, and the results are not as good. So you have to think about, when you're using the balloon, you're in trouble, and you have to find solution, and fast. It's a problem with abdominal compartment syndrome, and they die more. These patients die more, and there are a lot to do to get the technique better. And again, the balloon is just one of the tools. We can do all ruptures endovascular in general. At times, it's a time-consuming, and at times it will not work. But you have to think about the whole status of the patient, the hemodynamic status, what you can do and what you cannot do. And one of the things you can achieve with a balloon is to get some stabilization. And I think we have to investigate the role of Reboa and to see, we think it's clinically very good, but there is no real good data. We will discuss it here, and in Denver is the next stage, and of course on the different medias. And I have to say again, it's a great honor to be here. It's great work done here, research and clinically. Dr. Reva, Professor Samacholov, and the colleagues, they're doing amazing work, competing with honor with the American colleagues.
Any questions or comments? It looks like there's someone in the back here. Sam, why don't we get you, since we missed you last time?
Thank you, Tal. Can I ask a question about those of us that have got a setup for trauma? So someone like us who has a standard ER Reboa catheter set up and ready for trauma, is there anything, do you see any reason why we can't use that same kit in the same way for a patient with a ruptured AAA? And what are the practicalities of the next step and how you get around the balloon to put your stent in and all that kind of stuff? Can I just use the same kit, or is it different?
No, it's a problem because in ruptures, due to the aneurysm, in many cases, you will go up against the wall. It will be hard. At times, you will succeed, but at times, and we have several cases, and 2 done in the ER, you will go up and you will go to the aneurysms. So we would prefer imaging, and the time it takes time to go up. So it's an issue. It's not that easy. Trauma might be easier, the autostrada way up.
So I think that's why we often don't do it, but we have a common patient that probably everybody sees that sits in a resus bay, is 60, 70 years old, is talking, is well. You're phoning their wife to tell them they're going to die in an hour, and we sit and we watch them bleed to death in resus. Should I use it in that patient, or should I say, no, it's too risky?
If you think it's ethically right, of course you can use it. And I would do everything to save. If it's ethically okay and it's your call, yeah, of course. And you might go in. In some cases, you will.
Thanks. Thank you.
Dear Tal, thanks for your excellent lecture. It's Rico from the Netherlands. I think Sammy asked the first question because when we practice it also in the Netherlands, I noted that the anatomical complexity is a main issue, but also the diameter of the thoracic aorta is something to state. Because if you use the ER Reboa, you can go up a little bit more than 30 millimeters, and especially in elder patients in aneurysms, sometimes it's up to 40 millimeters, so that you get a really hard migration in there. What's your experience on that?
We have several. I don't think I had any problem even in thoracic. We used also the other balloons like the Tokai, and we used the big ones, 40 millimeters and 44 millimeters. I don't remember any problem with it, especially when they're in shock.
No, the reason I say it because just a recent case we had a migration of two balloons on there, and especially we used the EO Reboa, and then we had to change to a different balloon. But actually, we opened up the patient already to save it. But that's just something to state also.
Yeah,
and especially if you have something which is not over the guide wire, that you're at risk to create a free rupture.
I agree completely, and we use it on a stiff wire. When you're doing the ruptures, you have stability, you're working on a vector. It's completely another history. I agree.
Tal, may I comment on it? I respect your experience, the 100% EVA, but why don't you consider about the brachial access? If you choose brachial access, the balloon never migrate, and you don't have to pass the guide wire or catheter through the ruptured portion.
I agree completely, but we use the brachial to do chimneys, for example, so it's already occupied, and I can use the other side, but then I have a big respect to the thoracic, to the arch. We have, you will get, for example, in TVAR, there are 20% cerebral infarcts. I have big respect. I don't know, I would love to hear what Zoran, other vascular, Pirka, other opinions. This is my opinion only.
In my personal opinion, if we choose femoral artery as the access, before the inflation, I want to confirm the guide wire in the aorta, guide wire in not the ruptured portion. So in that case, the ER Reboa may be dangerous. ER Reboa directly go to the outside the ruptured aorta. So hopefully, probably the guide wire should be used.
I agree completely. Over the guide wire is, of course, the safest. Pirka?
Try to keep the discussion short because rupture EVA treatment is, as you're saying, a totally different ball game. But answering directly to the question, Stefan Ullon, who's probably done the most of the arch work or has done most of the cook work, he uses the right arm for his elective doings, and he thinks that there's no excess of strokes. 20% is probably overestimation. So you could use both arms, I think, but Stefan Ullon does it because he went to a new hospital and the setup is different. So the setup is actually very important. So we use always the left arm. But for rupture cases, which we simulate, and we start all our rupture cases, even if we do open sometimes, always we started by inflating the balloon. So the team is trained, and we have a simulation session every second morning. We published a paper which is now online on PubMed about the simulation, how it cut down the time from the patient coming to the OR having the balloon inflated from very long to very short, because our OR nurses were not experienced with the thing, but the simulation was very important. So I think here again we need practice, we need the team, and we need people working with it full time. But yes, there's a lot of questions about the rupture EVAR, but I think that's for another session.
Okay, thank you very much, Tal. So we're going to move on to our last speaker of this session. Zoran Rancic is going to come speak with us about emergent stent graft and Reboa for the unstable patient.
Dear Chairman, ladies and gentlemen, thanks for the opportunity to be with you, and I want to congratulate Victor and all the staff, because in 1 hour that I'm here I saw a lot of hospitality. Thank you for organizing this event. Maybe my talk is going to be to add some value to Tal, because there is almost the same what we are doing. So how I'm going to move the... So nothing to disclose. We know that the rupture, if not treated, is fatal, and for many years the open surgery was the only possibility to treat this patient. But in 1994 started the endovascular procedures, and then for the rupture, and this is the slides for Frank Witt, who did it the first case in Montefiore Hospital. And since then there is a discussion which
is better open on endovascular. There are studies, there are randomized control trials, and then someone have very promising and someone had very bad results. So is there any evidence that the center experience is important if we want to do endovascular treatment of rupture AAA? Yes, results improve after 30 rupture EVARs. We started in Zurich in 1998, the first EVAR, and we named it feasibility study. In total, we did 2 the first year. Nowadays, we are doing almost 20, and as Tal said, we are doing almost all by endovascular mean. This is the series we published together with Orebro and the Tal Hospital, when we saw that despite that we using rupture AAA with chimney parallel grafts, that means the patients are sicker, more complex procedure, we have less turn down, and you can see that the mortality is 22%. What is the most important for treatment of rupture AAA by EVAR is the point that you have to have your own standard operating procedure. That means if the patient has suspected aortic lesion, then you have to reduce the blood pressure, make CT scan. If this is the ruptured aortic, thoracic aorta, complicated dissection, then we do emergent TIVR. If not, we are making medicamented treatment, surveillance CT, and then delayed therapy. So when we talk, it's a package of different components. And this is the protocol who had to be defined in each hospital. This is how we are doing in our hospital. Patient shock room, CT scan, then we are going to make a decision procedure, yes or not, again, to make the procedure. And this is what I want to show you, that we identified 5 key elements, not we. This is what is important for the successful of the treatment. And Riboa is part of the hemodynamic. But if we forget that in the patient with rupture, we have to not give a fluids, to let permissive hypovolemia, and to make control hypertension, Riboa, it's not going to help a lot. So if the blood pressure is normal or high, we are going to lower the blood pressure. If the blood pressure is low and the patient is stable, we can talk to him. We are not going to give the fluids. If the patient is unstable, then we are going to give catecholamines. And in the case of hemodynamical crash, it's place for Riboa. We can do that before the CT, after anesthetic workup, or during the procedure. We are making almost 90% transfemoral access. That means unstable patients, we are used in 70 patients, the Riboa. As you can see here, what we are using, different hospital, different tools. We are using always 45 centimeter long sheet, felt French sheet, and we are using always compliant balloon. It's always balloon. It's always good to know how to use this. In some cases, I want to move it now. Can you move the slide? Can you move a slide? Okay, but in some cases we are using transaxillary access. This is, for example, patient with juxtarenal aneurysm. And in this case, maybe we would do a chimney, but the position for put a balloon was so difficult, and patient was completely unstable. Normally, we do not intubate the patient, but in this case, we intubated the patients. We dissect axilla. We are never going from transbrachial access. We can do this in the cardiovascular surgery clinic. Then we put a balloon. After putting a balloon, we stabilize patient. We started the procedure. Endovascular was not possible, so we decided to do it open surgical. So we opened the aneurysm, then we put a balloon through the graft, we occluded the aorta, and then we started to make anastomosis. Proximal anastomosis, clamped the aorta, distal anastomosis, and we made bypass to renal artery. What Tal did with chimney, in these cases, it was not possible, and we like to do chimney, but we use a balloon to stabilize patient as a tool for hemodynamic instability. What I want to share now for 1 and 30 minutes, it's important if you want to treat a rupture case, endovascular, you have to take and make always imaging with CT angio. During this time, on 403 patients, we lost only 4 patients. This is 1% of the patients. As in this case, you cannot know if there is a dissection, the patient has horseshoe kidney, and there is a retroperitoneal hematoma. With ultrasound, for you, it would be just ruptured AAA, and it is not. Also, you can see what is the proximal neck or what is the distal axis and say, okay, this patient is not possible to treat endovascular, we have to do it open surgical. Don't forget that oversizing is a big component and starting to talk a lot about this. Procedure, I'm not going to take a lot of time for procedure. For us, procedure EVAR is the same as a normal elective EVAR, just in case of rupture, where we have a stress and we have a hemodynamic instability. We are using also the parallel grafts. If the main killer is abdominal compartment syndrome, in our series, if the abdominal compartment is result, 25% people are dying. So every patient needs to have urinary bladder pressure measured in the shock room. Thereafter, if this developed compartment, we make a decompression. We are not using the closed decompression as they are doing that in Örebro. We are doing it open, and we have algorithm how to close the abdomen. In case when it's bleeding, we also can put a balloon into the limb of the, and then close the wound. If it's open the abdomen, we close it with a patch. What is important, team, there is less rupture. This is what we are doing with the simulator. Also in the patient with the rupture case, we simulate before the procedure, defining to identify best angulation, proximal, distal, and if you're going to use cross legs or not. Someone of you mentioned team training. Yes, using two balloons is extremely difficult, and that's what we are training. In conclusion, emergency stent graft is first choice for rupture AAA in our hospital and many other hospitals. It's about 5 key points to optimize management, and REBO is only one of these tools. Thank you very much for your time.
Пожалуйста, вопросы.
Your questions, please. People are thinking, but I have my question ready. If you managed, can you hear me? Yes, too. Can you hear me now? If you managed to put the stent graft, but the abdominal compartment syndrome developed, you have performed decompression, cut down of the anterior abdominal wall, and you have retroperitoneal hematoma, more than 1.5 liter volume. The risk of infection is very high. What do you do?
Question. This is a really practical question. And the answer is, I'm going to answer in that way. If for us, mostly rupture retroperitoneal, that means 2 liters retroperitoneal blood. Patient has abdominal compartment syndrome. We are going just to open abdomen. We are just going to decompress it. Because the killer is abdominal compartment syndrome, the pressure compressing of all the organs who is going to develop multi-organ insufficiency. If there is no bleeding, we are not going to go into hematoma. We are not going to try to remove hematoma, because when we do that, we are going to kill the patient. That means, and we are going to lose the quality of using minimal invasive EVAR, emergent EVAR for rupture AAA. On the other side, if we, whenever we are doing, I didn't have time to show this, whenever we are doing EVAR, we are making CT angio post-operatively, immediately post-operatively. There is a complaint, the people say it's not necessary or not, but in, let's say, in 5 to 10% we see, despite of the angiography, final angiography, no bleeding, we still see endoleak bleeding from internal iliac artery in the retroperitoneum. If we see like this, then we are going to open this and closure the rupture hole. And what I showed you with this patch, we are never going to try direct to suture the hole, it's not going to work, or we are not going to make conversion to open surgery. Then we are going to use the xenopericar patch. With the small bites, we are going to close this hole.
Спасибо. А как часто у вас развивается?
And how often you have endometrium when you install stent graft? How often endometrium is developed when you install stent graft?
This is endoleak type 2 from the internal iliac artery. Let's say we had in total 10 patients out of 300 we did endovascular, almost 300. That's, let's say, 3 of 10 of 300, 9%, 3%.
Пожалуйста, вопрос из зала.
More questions?
About infection, but with negative pressure wound abdominal closure, that's not an issue. I totally agree that the big killer is the hematoma or the intra-abdominal pressure. I saw the record 41 last week, which is quite high in the end of the operation. But there comes a question to Tal and you about the technique with the double balloon and so forth. That in the unstable patient, you first, of course, put up the balloon, and then you get the full occlusion of the zone 1, and then you resuscitate the patient, and then you maybe go to partial occlusion. But then actually the aneurysm maybe starts to bleed again before you get the contralateral limb in place and so forth. So during this time, maybe it is growing the hematoma, the retroperitoneal hematoma. And sometimes we see these patients that come in and they have quite a flat, painful abdomen, but at the end of the operation it's very distended. And we have thought, I think Tal you said that long occlusion times will induce the reperfusion and the swelling of the bowel, which is true. But on the other hand, if we don't occlude, then they continue to bleed. So do you have any experience? I know there's no data or science, but do you know what is your opinion? Should we occlude the aorta in order to keep the hematoma down, or should we use partial occlusion in order to not have the bowel ischemia?
I have to say that I want to get the patient out of the table. When it's out of the table, I want perfusion to the intestines. Then I can take out some of the blood. We did in 17 patients with active thrombolysis when we know that they don't bleed. So I think there are ways to do it when we decompress laparotomy or some other methods. But it's a great issue. I don't know. I don't know more.
I will try. Thank you for your comments. You're completely right. There is no science. But I will say like this. We make always preoperatively urinary blood pressure measurement. Then we see at the end of the procedure, we see if there is a difference. Of course, there is a bleeding. We are doing always with 2 balloons. That means when we say reboa, that means just reboa to put a balloon and then make stent graft. It's a bit not work at all. That means we have to play a 2 balloon. At first we are putting a balloon above, then we are putting a main graft, and then a contralateral we are putting a balloon in the main body of the graft. Then we deflate the first balloon, then we cannulate from the contralateral gate. That means we are playing with 2 or 3 balloons. So that means the complete exclusion of the aorta means that you have to use with 2 or 3 balloons. And this is what we are, I showed the last slide, we are making this team training with in a simulating room, because you have to know the colleague who is working you, he has to be aware how to use this. If you try to use 2 balloons and you never did it, it is almost impossible that it will work, or it will be very difficult to work. And also you have to communicate with anesthesiologists, because inflating a balloon have to react. So let's say use 2 balloons is the only option in patients with a rupture. And of course there is a bleeding. And the bleeding at the end, if there is a compartment syndrome, we have to decompress. We are very liberal to decompress. Some centers are very restrictive, and maybe this is the difference.
So let me get this clear.
I suggest we torture Zoran further, but we have a pleasant procedure for which we need time. Now can you hear me? We have a very pleasant procedure and we need some time for it. So something was said about 1 question more, though, and then a pleasant procedure.
Different approach than Tal. We also use 2 balloons and tend to occlude, and then you get the trade of the graft maybe coming a bit down and so forth. But Tal said that he prefers to use partial occlusion. Now you're saying you're using full occlusion, and then you're putting into the body.
It's no question. It's discussion.
Okay. We will discuss during the break.
A lot to learn.
Спасибо.
Yeah.
Thank you. Ladies and gentlemen, I would like to complete our session with a very pleasant event. Aside for oral presentations, we had post presentations, and our colleagues have selected 2 best post presentations. And now it will be an award ceremony. Victor Reva, please.
Please, Natalia Resovna Chornaya, come on the stage. We want to award you for the presentation dedicated to the hemorrhages in liver traumas, the experience of Sklifosovsky Institute.
Society is meant to get people inside, and that you can join reduce fees to all the activities, and of course get some very nice present from Dr. Reva here.
This is from society.
From the society, I mean, yes, of course. So, okay, maybe we should take a photo together? Yeah. Okay.
Okay, now we're ready for a break. We'll start back. Oh, one more. Sorry, my bad.
And the second, first prize is Alexander Karatkih from Tumen. Their poster is devoted to angiographic embolization in case of gynecology, obstetric bleeding. Everyone can become a member of the EVTM society, and Tal Hor has a proposal for our Russian visitors. So please announce what the society is and how they can. So you can become a member here at the registration desk if you want, and Tal will talk about it.
Very shortly, this is a cooperation. We want to get people involved. It's a very low annual fee that we propose, and especially for our Russian friends. And we want to get people involved. And for this, we will get a lot of information and, of course, reduced fee for the workshop, for the symposium. We're working on this, and we will try to do our best that this will give more than it takes. So this is a great cooperation platform, and we will be very happy if people join. Thank you very much.
Okay, now a break, and we will start back in 25 minutes. Thank you.